Hi everyone, welcome back to our module on bone tumors and tumor-like lesions. Now we move into bone tumors, which are an important topic in musculoskeletal pathology. Bone tumors are abnormal growths that arise from bone or cartilage tissue. They can be broadly classified into two major categories: benign tumors and malignant tumors. Benign bone tumors typically grow slowly, they remain localized and rarely spread to other parts of the body, whereas malignant bone tumors, on the other hand, grow aggressively and have the potential to metastasize. One important concept that helps in diagnosing bone tumors is that many tumors have a characteristic age distribution and typical location within the bone. For example, certain tumors occur predominantly in children, while others are more common in adults. So, therefore, in exam questions, the key strategy is to combine three clues: the patient's age, the tumor location in the bone, and characteristic radiological pattern. Bone tumors can also be classified based on whether they originate in the bone itself or spread from another organ. So primary bone tumors originate directly from bone cells or cartilage forming cells. Examples includes osteosarcoma, Ewing sarcoma, and chondrosarcoma. Although these tumors are important academically, they are actually less common than metastatic bone tumors. Most common bone tumors are the metastatic bone tumors. They occur secondary to metastasis from other primary organ-associated tumors. So they spread from other organs to the bone through the bloodstream. The most important primary cancers that metastasize to the bone includes the breast cancer, prostate cancer, lung cancer, kidney cancer, and thyroid cancer. So in fact, metastatic tumors are the most common malignant tumors that are found in bones. Age is one of the most important clues in identifying bone tumors. Certain tumors are predominantly seen in children and adolescents. For example, osteosarcoma and Ewing sarcoma commonly affect teenagers, whereas young adults between 20 and 40 years of age are more likely to develop giant cell tumors. In contrast, older adults are more likely to develop chondrosarcoma or metastatic bone tumors. So, therefore, whenever solving questions, always begin by asking what is the age of the patient. So, this single clue can immediately help us narrow the list of possible tumors. Another important distinction is between benign and malignant tumors. Benign tumors typically grow slowly and have well-defined borders. They usually remain localized and rarely invade surrounding tissue. Examples of benign bone tumors include osteochondroma and osteoid osteoma. Malignant tumors, in contrast, they grow rapidly and invade surrounding tissues. And they also have a potential to metastasize to other organs. So, examples of malignant bone tumors include osteosarcoma and Ewing sarcoma. So understanding the difference between these malignant and benign tumors helps us interpret imaging findings and also how they behave clinically. Radiological imaging is extremely helpful in diagnosing bone tumors because many tumors have characteristic imaging patterns. For example, osteosarcoma produces a sunburst appearance. So this is an imaging of osteosarcoma, and the characteristic pattern is sunburst pattern, which appears as layered bone formation on imaging. Another example is soap bubble appearance in giant cell tumors. So this image shows the characteristic soap bubble appearance at the wrist joint. So, sorry, at the ankle joint. So, this is a characteristic soap bubble appearance in that is seen in giant cell tumors. So, the other one is Ewing sarcoma, which classically shows an onion skin periosteal reaction. So, this onion skin periosteal reaction in Ewing sarcoma, which this appears as layered bone formation on imaging, whereas sunburst pattern is due to aggressive periosteal reaction, and that is seen in osteosarcoma. Osteochondroma is the most common benign bone tumor, so it appears as cartilage-capped bony projection that grows outwards from the surface of the bone. These tumors typically arise near the growth plate in the metaphysis of long bones. The common sites includes the distal femur, proximal tibia, and proximal humerus. So in many cases, osteochondromas are discovered incidentally on imaging because they often produce few symptoms. Osteochondroma develops due to abnormal growth of cartilage from the growth plate. So the cartilage cap undergoes endochondral ossification, which results in a bony outgrowth that remains continuous with the parent bone. A genetic condition known as hereditary multiple exostosis can cause multiple osteochondromas to develop throughout the skeleton. So this condition is caused by mutations affecting cartilage growth regulation. Osteoid osteoma is another benign bone tumor that is, but no, it has a very characteristic clinical presentation. It occurs in young adults and commonly affects cortex of long bones, specifically such as the femur and tibia. The most classic symptom is severe bone pain that worsens at night time, and but this pain is relieved dramatically by NSAIDs. So this occurs because the tumor produces large amounts of prostaglandin, which can cause pain and inflammation. So relief with NSAIDs is therefore a very important diagnostic clue in cases of osteoid osteoma. Osteoblastoma is similar to osteoid osteoma but differs in several key ways. It tends to be larger and often occurs in the posterior elements of the vertebrae. Unlike osteoid osteoma, the pain associated with osteoblastoma does not typically improve with non-steroidal anti-inflammatory drugs, and patients might present with persistent bone pain and sometimes with swelling in the affected area. So, although it's considered benign, osteoblastoma can sometimes be locally aggressive. So, this is a key characteristic feature, and the other key characteristic feature that differentiates it from osteoma is that the pain doesn't improve with non-steroidal anti-inflammatory drugs. Giant cell tumor of the bone is a locally aggressive tumor that typically affects young adults between ages of 20 and 40 years. Unlike many other bone tumors that arise in the metaphysis, giant cell tumors arises in the epiphysis of long bones. Common locations includes distal femur and proximal tibia near the ankle joint, distal femur and the proximal tibia near the knee joint. So, on imaging, the tumor often appears as a soap bubble lesion that we can see in the image, and this is due to its lytic nature. Histologically, it contains numerous multinucleated giant cells. Histologically, it contains numerous multinucleated giant cells. So, uh, multinucleated giant cells are a characteristic feature of giant cell tumors of the bone. Now we move into malignant bone tumors. These tumors are aggressive and are capable of invading surrounding tissue and metastasizing. These tumors are aggressive and are capable of invading surrounding tissue and spread to the distant organs. Patients often present with progressive bone pain, swelling, and sometimes pathological fractures. Three important malignant bone tumors that are particularly important and are particularly tested on exams includes osteosarcoma, Ewing sarcoma, and chondrosarcoma. They are often present with progressive bone pain, swelling, and pathological fractures. Osteosarcoma is the most common primary malignant bone tumor in adolescents. It arises from the malignant osteoblasts that produce osteoid matrix. The tumor usually develops in the metaphysis of long bones, particularly near the knee. Common sites includes the distal femur, proximal tibia, and proximal humerus. Patients typically present with progressive bone pain and swelling. So whenever an adolescent presents with uh, progressive bone pain and swelling, we have to think about the possibility of osteosarcoma. And because osteosarcoma is mainly seen in adolescents and it's the most common primary malignant bone tumor in adolescents. Osteosarcoma produces distinctive radiological findings. Most classic feature is sunburst periosteal reaction, which occurs when rapidly growing tumor pushes the periosteum towards the outside. Another important feature is Codman triangle, which forms when the periosteum is lifted away from the bone. Risk factors for osteosarcoma include Paget's disease of bone, previous radiation exposure, and mutations in the retinoblastoma gene. Ewing sarcoma is a highly malignant bone tumor that primarily affects children and adolescents. It belongs to a group of tumors known as small round blue cell tumors, also called as neuroendocrine tumors. Uh, it arises in the diaphysis of the long bones. So, Ewing sarcoma is mostly seen in the diaphysis of long bones. The previous one, the osteosarcoma, is mainly seen in the metaphysis. The common sites includes femur pelvis and tibia. It is strongly associated with chromosomal translocation between chromosomes T11, 22 translocation. One of the most important characteristic features of Ewing sarcoma is the onion skin periosteal reaction that is seen on imaging. You can also see the image attached on the screen. So this is the characteristic onion skin periosteal reaction that is seen in Ewing sarcoma. So this layered appearance results from repeated cycles of bone formation beneath the periosteum. So patients often present with bone pain, fever, swelling, which can mimic osteomyelitis. So recognizing the onion skin pattern helps us distinguish Ewing sarcoma from other bone tumors. So the characteristic feature of Ewing sarcoma that can be found out through radiological imaging is the onion skin periosteal reaction. It's nothing but layered appearance because of repeated cycles of bone formation that occurs beneath the periosteum. Chondrosarcoma is a malignant tumor that produces cartilaginous matrix. Unlike osteosarcoma and Ewing sarcoma, it usually occurs in middle-aged or older adults. Common sites includes the pelvis, femur, and the shoulder girdle. Patients typically present with deep and slowly progressive bone pain. Radiological imaging often shows lytic lesions with areas of calcified cartilaginous matrix. One characteristic feature is ring and arc calcification, which reflects the cartilage nature of the tumor. Because chondrosarcoma grows relatively slowly, symptoms may develop gradually over time. So, this is characterized by a gradual increase in symptom severity. Fibrous dysplasia is a tumor-like lesion rather than just a true neoplasm. So, in this condition, normal bone is replaced by fibrous tissue due to mutations in a gene called GNAS gene mutation. So, this abnormal tissue weakens the bone and interferes with the normal bone remodeling. So, this abnormal tissue weakens the bone and interferes with normal bone remodeling. This interferes with normal bone remodeling. So it weakens the bone. Radiologically, fibrous dysplasia produces a ground glass appearance of bone. If it affects a single bone, it is called as monostatic, whereas when it affects multiple bones, it can be called as polystatic. Fibrous dysplasias can occur as a part of McEwen-Albright syndrome. So this syndrome has three major features. The first thing is fibrous dysplasia of bone. The other one is endocrine abnormalities such as precocious puberty, and the third one is cafe olate skin pigmentation. The cafe olate spots in this syndrome typically have irregular borders, so it's just like uh, not a non-elevated lesion with a characteristic pigmentation. So this cafe olate pigmentation is mainly seen over the extremities and typically on the backside of the body. The classic triad in McEwen-Albright syndrome is fibrous dysplasia of bone, endocrine abnormalities such as precocious puberty, and the third one is cafe olate pigmentation. Bone cysts are fluid-filled cavities within the bone. The two common types includes simple bone cyst and aneurysmal bone cyst. Simple bone cyst is also called as unicameral cyst. These lesions occur usually in children and adolescents and may weaken the bone structure. As a result, they sometimes present with pathological fractures. On imaging, bone cysts appear as well-defined lytic lesions. These slides uh, emphasize the most important exam patterns. So I'd like to request all of you to just give me keen attention to these next coming slides. So metastatic tumors are actually the most common malignant tumors affecting the bone. So common primary cancers that spread to the bone includes breast, prostate, lung, kidney, and thyroid cancer. Certain cancers produce characteristic bone lesions. For example, the lungs and kidney cancers typically produces osteolytic lesions. So the lung and kidney, just remember the what you breathe and how you excrete. So lungs and kidney, what they do is they typically produce osteolytic lesions, whereas prostate cancer typically produces osteoblastic lesions. So finally, remembering the location pattern also helps us diagnose tumors very quickly. So metaphysis tumors suggests metaphysis tumors suggests Osteosarcoma, diaphysis tumor suggests Ewing sarcoma, and epiphysis tumors suggest what's that, giant cell tumor. So recognizing these patterns allows us easily diagnose all those associated cancers. So these metastatic bone tumors can usually produce different kinds of bone destruction, as we already discussed. Osteolytic lesions are more commonly seen in lung and kidney cancers, and they present with bone destruction, whereas osteoblastic lesions stimulate excessive bone formation. The classic case is a patient with prostate cancer who just comes to the OPD with characteristic radiological imaging showing an osteoblastic lesion. So there's excess bone formation. Some cancers produce a mixed pattern showing both bone destruction and abnormal bone formation. So recognizing these radiological patterns helps us identify the primary cancer that is responsible for the metastasis. Osteoclastic lung and kidney cancers, osteolytic lung and kidney cancers, whereas osteoblastic is mostly seen with prostate cancers. Patients with bone metastasis often present with persistent bone pain that gradually worsens over time. The affected bones become weakened, which increases the risk for pathological fractures. When metastasis involves the spine, they may compress the spinal cord or nerve roots. So this can lead to symptoms such as back pain, neurological deficits, or weakness in the limbs. So another important complication of bone metastasis is hypercalcemia. So just we have to remember that another important complication is hypercalcemia, which occurs due to excessive breakdown. So whenever there's excessive turnover, excessive breakdown and bone formation happening, what happens is more and more calcium is released into the bloodstream. So because of these all these kinds of potentially serious complications like persistent bone pain, pathological fractures, spinal cord compression, and hypercalcemia, these bone metastases require prompt evaluation and management without any delay. One of the most useful strategies for identifying bone tumors is to remember their typical location within the bone. We have already been discussing this. I will just like to revise the same thing again. Epiphysis, whenever you see a malignant tumor, just think of giant cell tumor. And when you see some uh, invasive kind of mass in the diaphysis, think of an Ewing sarcoma. Whereas in metaphysis, if you see something, just think of osteosarcoma and osteochondroma. To conclude this section, let's just review the most important diagnostic patterns that are used in questions and how we can use pattern recognition as a strategy to solve questions on USMLE Step 1 and NEET PG. So a teenager with a metaphyseal tumor showing a sunburst pattern. Sunburst pattern is nothing but just exaggerated periosteal reaction leading to abnormal bone growth. So whenever a teenager the metaphyseal tumor shows a sunburst pattern that can strongly suggest osteosarcoma, whereas a child with a diaphyseal tumor and onion skin periosteal reaction, this can indicate Ewing sarcoma. A young adult with an epiphyseal tumor showing a soap bubble appearance, it suggests giant cell tumor, whereas an older adult with a cartilage producing tumor, it suggests chondrosarcoma. Finally, when multiple bone lesions appear in an older patient, metastatic disease should be strongly suspected. So, recognizing these classic patterns allows us to quickly and readily identify bone tumors in clinical scenarios. Teenager, metaphysis, sunburst pattern, osteosarcoma. Child, diaphysis, onion skin periosteal reaction, Ewing sarcoma. Young adult, epiphysis, soap bubble lesion, giant cell tumor. Older adult with a cartilaginous tumor, chondrosarcoma. Multiple bone lesions in an older patient, think of a metastatic disease. Before ending the video, I would like to request all of you to subscribe and keep supporting. So, this lecture series is provided free and is open access for all students. If you find it useful and wish to support its development, I would really welcome voluntary contributions. Those contributions can definitely help us improve in a lot of aspects, build a team or something like that. You can pay with any of the payment methods on the link that is on the screen, and that's also pinned in the description. This lecture series is started with a motto to just buy all of those aspirants who are sitting down, uh, buy those people some time to just sit down and actively solve questions. So when you actually know what's actually important and what's actually tested on exams, and you just open your book and you start reading it by yourself, you tend to remember and memorize it more. So this is just started with a motto to help students find out some more time, help students get some time to actually get involved with active book reading and actively solving question banks. If it helped you, I'd like to request all of you to subscribe and keep waiting for many more videos and exciting content coming up. In the next video, we're going to study about back and spinal disorders, and we are going to end this musculoskeletal system series with an eighth video on metabolic bone disorders. I hope you like this. I'll get back to you very soon. Thank you.